Hello everybody, my name is Decraene and I'm going to tell you a bit more about our recently published paper, the Tyneside Pegboard Test for unimanual and bimanual dexterity in children with unilateral cerebral palsy and its association with sensorimotor impairments. Cerebral palsy is a permanent disorder, but non-progressive, due to brain damage that occurs in the prenatal phase or 2 to 3 years after birth. This can cause different sensorimotor impairments in the body. 44% of this population represents only impairments on one side of the body, which is called unilateral cerebral palsy or hemiplegia. In these children, the sensorimotor impairments are mostly situated in the upper limb.
Recently, the Tyneside Pegboard Test was developed to measure both unimanual and bimanual dexterity, which is the ability to perform fast coordinated movements. For the unimanual task, the child have to move 9 pegs from one board to the adjacent board as quickly as possible as they can. This task can be performed in 2 directions and with both hands. The task also consists of 3 different peg sizes: large, medium, and small pegs. In the bimanual task, pegs were picked up one by one with one hand, passed through a hole to the other hand, and placed in the adjacent board. This task can be performed in 2 directions. Next to this, these tasks are only performed with the large pegs.
Nevertheless, the combined impact of the sensorimotor impairments on unimanual and bimanual dexterity had not yet been shown. Therefore, we first investigated the psychometric properties of the Tyneside Pegboard Test, more specifically the known group validity, concurrent and construct validity. And next to this, we also investigated the combined impact of different sensorimotor impairments on unimanual and bimanual dexterity in children with unilateral cerebral palsy. We looked at the impact of spasticity, grip strength, exteroception, stereognosis, and mirror movements.
The unimanual dexterity tasks were performed with the more impaired hand, and the average of both directions was calculated, resulting in 3 different parameters according to the peg size. The bimanual dexterity task consisted of 2 different parameters for each direction, namely from the more impaired to the less impaired hand and from the less impaired to the more impaired hand.
Known group validity was further investigated using the Manual Ability Classification System, or the MAX levels. For concurrent validity, we compared the unimanual TPT task with the widely used Jepson-Taylor hand function test. For construct validity, we looked at the bimanual TPT task and compared them to the Assisting Hand Assessment, Able Hand Kids Questionnaire, and the Child Hand Use Experience Questionnaire.
For the second aim, we measured different sensorimotor impairments. Spasticity was measured with the modified Ashworth scale, grip strength was measured with the Jamar dynamometer, stereognosis was assessed through tactile identification of 6 familiar objects, exteroception was determined with a clinical test of touching the index finger, and mirror movements were investigated with the windmill task, providing us information about mirror movement similarity and mirror movement intensity.
In total, we measured 49 children with unilateral cerebral palsy, aged 6 to 15 years. As most dexterity assessment consists of a maximum time, like the Jepson-Taylor hand functioning test, we decided together with the developer of the task, Professor Bazu, to implement a maximum time or a threshold for each child that could not perform the task or performed it longer than this maximum time. In this way, we could still include the whole spectrum of children with cerebral palsy. Our results showed that the Tyneside Pegboard Test was able to distinguish between the different max levels, indicating that known group validity was established. Next to this, concurrent and construct validity was also established.
For the influence of the sensorimotor impairments, we found that stereognosis is the main predictor for both unimanual and bimanual dexterity. Unimanual dexterity was additionally explained by grip strength and mirror movement intensity in the most impaired hands. Next to this, bimanual dexterity was additionally determined by spasticity and mirror movements in the more impaired hands.
To conclude, our results show that the Tyneside Pegboard Test is a valid tool to measure unimanual and bimanual dexterity. Next to this, our results show that both motor and sensory impairments are important for manual dexterity in children with unilateral cerebral palsy, but it also highlights the negative effect or impact of the somatosensory function, mainly stereognosis or object recognition. Are you interested in more information? Then you can always go check out our full paper in the Developmental Medicine and Child Neurology. Thank you very much for your attention.